This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
As general practitioners, we're the best placed specialty to deal with addiction issues. We understand better than anyone the overlay of, social context, physical issues and comorbidities. We know people and we know their families and we know their backgrounds, but also we can deal with the physical sequelae of addictions as well, really well. So, I think as GPs, it's a really, really rewarding aspect of general practice.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. With addiction increasingly recognised as a chronic medical condition akin to diabetes or hypertension, GPs are uniquely positioned to intervene early, deliver effective care and support a sustained recovery. When it comes to opiate dependence, codeine use disorder represents a significant proportion of new presentations for opioid use disorder in addiction clinic settings in Ireland, potentially driven by its relative ease of access over the counter. To discuss management of codeine misuse and dependence in primary care, I'm joined today by Dr. Bernard Kenny. Here's Bernard.
Hi, I'm Bernard Kenny. I'm a dual qualified GP and pharmacist. I'm a GP specialising in substance misuse, working in Waterford and elsewhere in the southeast of Ireland. I'm also the Director of Addiction Management in Primary Care with the Irish College of GPs.
In today's episode, Bernard discusses codeine availability and misuse in the Irish context, clinical pearls around safe prescribing, and managing codeine use disorder with a focus on sublingual buprenorphine, which has replaced methadone as the first-line pharmacological intervention. Bernard has a real depth of knowledge in this area, which he shares with me throughout our conversation, and I hope you'll find it valuable to your practice. During the conversation, Bernard also gives some detail around the newly revised foundation course in addiction management, which is now available free on the Irish College of GPs website. The course is also suitable for GP registrars and practice nurses, and completing the foundation course is a prerequisite for those interested in pursuing a Level 1 opioid substitution therapy or OST contract with the HSE.
That's right, John. We have a new fully online modular course addressing common addiction issues you'll encounter in general practice. So not only do we deal with things you might expect like opioids and opioid use disorder, we deal with illicit opioids, but also things like over-the-counter opioids in the form of codeine and commonly prescribed opioids of misuse like tramadol, morphine, OxyContin, an approach you would take to that in general practice. As well as opioids, we also cover common addictions you'll encounter like alcohol, benzodiazepine, Z drugs, and also things like stimulant addictions like cocaine, and other addictions like cannabis and behavioural addictions like gambling. It's eligible for a half-day GMS study leave, but it also is accredited for 6 continuous medical education points or 6 CE credits.
And I guess while it's got a broad-based approach to addiction more generally, one of the outcomes from the foundation programme is the ability to prescribe OAT as a Level 1 prescriber. Is that right?
That's correct, John. So the course covers how you might address these common addictions encountered, but it's also one of the prerequisites for becoming a Level 1 prescriber. So this is a separate contract GPs can obtain from the HSE, which is a funded additional contract, and it allows GPs to be able to prescribe and take care of people who have an opioid use disorder. Now, the Level 1 qualification allows you to take over people who are initially commenced in opioid agonist therapy. So these are people who may have you inherit from a different practice or may have been initiated via a HSE, a specialist addiction clinic.
Today we are focusing on codeine misuse and dependence. And this is something that GPs would see quite frequently, although I guess there is still a hidden component to this. And just to introduce the topic, I believe you have a memorable case that you wanted to share with us.
Yeah, I'd like to give you an example of a not untypical case, which we see quite a lot of, particularly those of us with special interests in addiction. And I think, a lot of GPs out there aren't aware of the sheer scale of the problem. So I'd like to talk about Anne, who's a 46-year-old woman who had, recent history of anxiety disorder, but then also additional issues with marital breakdown and issues with her job as well. So she's under a lot of pressure. Started buying a lot of codeine combined with ibuprofen over the counter, initially to manage menstrual pain, but then she subsequently found that she had a general sense of well-being and calm associated with the codeine use, and that led her to use more and more of it. So Anne really presented to me an absolute crisis. I had been contacted by the emergency department physician, and they outlined to me that Anne had attended with a very, very dangerously low potassium. She had an acute kidney injury with a really elevated creatinine, and her hemoglobin was only 4.3, so she was incredibly anemic, very, very low hemoglobin, and she required transfusion. And as it transpired, it turned out that all of this was down to Anne using multiple packets of codeine combined with ibuprofen. So the issue is people can become addicted to the codeine, and sort of as a byproduct, this product is combined with ibuprofen. So those huge quantities of non-steroidal anti-inflammatories can play havoc with the gastrointestinal system, the kidneys, the liver, and also have lots of other impact regarding risk of bleeding as well. So huge issues with that, and not an uncommon scenario, unfortunately. So it turned out when I finally met Anne and she was discharged from hospital, it turned out she had initially been prescribed codeine 30 milligrams, paracetamol 500 milligrams by her GP many years before that. So codeine was an agent that she was familiar with, knew the effects. She felt that it brought her a sense of calm in her life, and also allayed some of that anxiety she felt. And unfortunately, it's something she turned to again in over-the-counter forms. As we know, a lot of GPs now are very cautious about their prescribing of opioids, particularly outside the context of cancer-related pain. So she turned back to codeine, but in this case in the form of over-the-counter codeine.
One of the interesting things that strikes me from the case you just outlined, Bernard, is the fact that it wasn't Anne that reached out to you and the addiction services. It was a consultant or a colleague in the emergency department. Is that unusual in codeine, that people's physical health catches up with them, as opposed to approaching the services having identified the problem with the codeine itself?
Codeine, it's often a very, very hidden addiction, John. And it's something that people, there's a lot of shame associated with it. And because it's available over the counter, people initially see it as a sort of a benign, harmless substance. And unfortunately, then it can kind of get a hold on people. So people start to crave increased doses of codeine to have the same effect. In Ireland, codeine available over the counter, so codeine without a prescription, is always added to another ingredient. So by far, I'm not picking any brand in particular here in this, but by far the most common presentation we would see is with codeine 12.8 milligrams combined with ibuprofen 200 milligrams. And unfortunately, the increased numbers. So we would have people that would be attending 3 or 4 different pharmacies a day. The pharmacies are limited in the amount they can supply to a person, so they're limited to 1 packet per sale, and there's certain strict criteria that would go with that sale. So they'd have to explore the indication. Have they tried anything else? Have they been using it longer term? But of course, people with addiction issues will quickly learn how to answer those questions appropriately. So many people that attend will, have had a very, very difficult time traveling often very large distances to try different community pharmacies, often 3 or 4 different pharmacies each day. And I've had people that would visit, 20 different pharmacies every week just to meet their codeine requirement. And it wouldn't be uncommon to have someone buying 3 to 4 packets of 24 codeine 12.8 milligrams combined with ibuprofen 200 milligrams per day. And it's interesting you say about the hidden nature of that. Often, people's close relatives won't even be aware of it. So spouses, children, they won't be aware of that addiction. And it's something that people can often keep hidden until a crisis emerges, until they have a major gastrointestinal bleed, until their hemoglobin drops, or they have an acute severe kidney injury. So often that's when it becomes apparent. And that's the point that we often are involved with managing a person.
That entire part of the story around going from pharmacy to pharmacy also brings up the idea of Ireland as an outlier in terms of the availability of codeine in the first place as an over-the-counter product, which is something that surprised me.
Yeah, it's a really good point to mention. So we're unusual within the European Union and one of the few countries that still has over-the-counter codeine for sale off prescription. And of course, there's huge risks associated with that. So, and it's all really driven in the first instance by the addiction risk, I guess. So we have some checks and balances. So the pharmacies do have a series of questions they ask in order to prevent people overusing it. But there's no central register of people who've been sold codeine products over the counter. So there's nothing to stop individuals travelling pharmacy to pharmacy or indeed returning to the same pharmacy a few days later and buying another packet. So pharmacies are doing their best, but it's easy to circumnavigate the rules within the community pharmacy around that as things stand. So we do sell over the counter. The UK also do, but most other European countries and certainly countries within the EU have moved to remove codeine as an over-the-counter product because of the well-documented harms associated with addiction from codeine use disorder, which are well understood at this stage. So I believe the HPRA are looking into this at the moment, and the benefits and harms of it being available for provision over the counter without a prescription are currently being examined.
I'm sure most of us are aware that codeine is a weak opioid, but would you mind just providing a quick refresher on how it works?
Of course, John. So codeine, as you said, it's a weak opioid. It's often the first step on the WHO pain ladder when it comes to opioids. So how it works, once you ingest it, roughly about 10 to 15% of codeine is enzymatically converted in the liver to morphine. So even though it's a weak opioid, it exerts its effect via active morphine metabolite, and that's how it works. And then, of course, it's centrally, so it works in the brain and also works peripherally, primarily on the mu opioid receptors. So it's a good, it's a painkiller. It's often used for things like headaches, menstrual pain, and muscle pain would be the most common uses for over-the-counter codeine. And of course, we'd see prescribed codeine used for things like osteoarthritis and often in kind of chronic pain conditions and cancer type pains as well.
Now that we know what codeine is and what it does and its addictive potential, what steps can GPs take in their day-to-day practice to minimise the risks to their patients of developing misuse and dependence?
I think as GPs, we're all well aware of the people we're prescribing regular codeine for. It's commonly in the form of codeine, 30 milligrams, paracetamol, 500 milligrams. So common brands we'd be familiar with like Solpadol, Capaic or Tilex. And we all know the people we're issuing those prescriptions for monthly. But I think, GPs, we're getting better and better at recognising the risks associated with prescribed opioids. Even the, so-called weak opioids like codeine, we're aware of the potential harms and the addiction-related harms. And of course, the HSE have recently released an over-prescribing report on opioids, benzodiazepines, Z-drugs and gabapentinoids. So there is a kind of a highlight on this issue at the moment. But as GPs, we're getting better. And it's keeping an eye on things like using the lowest effective dose for the shortest duration of time. If you are deciding to initiate an opioid in practice, look at the reasons why. Are there alternatives that can be explored? Can you look for can you choose options like paracetamol or non-steroidal anti-inflammatory? Or is there a non-pharmacological option to help alleviate the pain like physiotherapy or other supportive therapies which may be of benefit? And then if you are deciding to commence an opioid, look at the patient characteristics before you go ahead with that prescription. So are they someone who's previously struggled with alcohol? Have they previously had issues with benzodiazepines like diazepam or Z-drugs or sleeping tablets? Or do they have a family history of addiction? And then if you are deciding to prescribe, make sure you have a definite endpoint. Is it a bridge to something? For example, is it somebody that you have a total knee replacement coming up in a month's time and the non-steroidal anti-inflammatories and paracetamol are no longer effective, or they have a degree of kidney disease and you don't want to use that anymore? So thinking about those options, thinking is there an endpoint, and then always discussing with your the person in front of you, the potential risks of addiction. I think it's something that as GPs we sometimes skirt around, but it's important to address that, because a lot of people won't be aware of that potential risk. A lot of people do become addicted to codeine, and also I think if people are informed regarding the addiction risk, and you explain your concerns and the potential issues with that they're going to be more amenable to having a taper or an endpoint once it's no longer warranted or unnecessary. And of course, a lot of opioids are prescribed and they're not hugely effective. So if you speak to someone, you've started cocodamol, codeine mixed with paracetamol, and they say, well, I haven't felt a huge benefit, stop that medication. There's no need to continue it, and you don't need to ramp it up. If it's not working, it's unlikely to be effective at a higher dose. So they're all things you can do in the first instance prior to commencing it, or indeed when you're considering a prescription for an opioid. However, like you said, John, lots and lots of people are on long established opioids, and most commonly probably in the form of codeine in GP. I think we're a bit more careful with things like OxyContin and Oxynorm and Tramadol and morphine, but codeine is still very, very common, and rightly so. It's the first step on the opioid ladder, according to WHO recommendations. But I think we all know we have lots of people on our books that are coming in monthly and regularly. So when you have decided to initiate and you come to that shared decision, take measures like keeping one prescriber seeing the single patient each time. So don't be having that person going to different doctors. Make sure you can implement measures like things like phased dispensing, because that reduces the risk. You're not giving out huge quantities of tablets to a person with the potential risk that they might run out early or take more than they're supposed to per day. So you can take measures like that to help reduce the risk.
In those unfortunate cases where patients may develop an addiction to codeine, OAT can be an option for them too.
Absolutely, John. So OAT, or opioid agonist therapy, it's what we call products like methadone and buprenorphine now. For a long, long time, I guess, people would have thought of those medications only in the context of heroin, and the only opioid agonist therapy as methadone. So that's the green liquid lots of people will have ideas about. And I suppose, unfortunately, over the years, because of that strong association with heroin, there's a lot of stigma around methadone and methadone maintenance therapy and all that goes with that. So methadone's the treatment that's been around for a long, long time. But in the last, 5 to 10 years, buprenorphine has come in, which is another form of opioid agonist therapy. Rather than a liquid you ingest, it's a small sublingual tablet which is dissolvable under the tongue. And it's an incredibly effective treatment for over-the-counter opioid use disorder in the form of codeine, but also for prescription opioids and indeed heroin use disorder as well. So the way buprenorphine works is it's a partial opioid agonist rather than a full opioid agonist. So it's it partially activates the receptor. So with each increasing dose of buprenorphine, because it's only partially activating the receptor, you get a ceiling effect, whereby added doses of buprenorphine don't have substantially increased opioid risks, like impacts on your breathing response or respiratory suppression effects. So you don't see that. But buprenorphine has another unique feature in that it binds very tightly to the opioid receptor. So if you ingest another opioid, like for example codeine, morphine or heroin, those other opioids won't have a significant effect because the buprenorphine is already bound to that receptor. So it blocks other opioids having an impact. So it's really, really useful as a harm reduction tool in the first instance. So because it partially agonizes the receptor or partially activates the receptor, it controls people's withdrawal symptoms, it controls their cravings, so it breaks that cycle in addiction. But also we know addiction is characterized by periods of relapse. So if somebody does have an issue where they fall back into opioid use, that those opioids won't have an impact. So it allows people to stay on track, but also minimizes the risk of accidental overdose. So it's a hugely beneficial medication. And we know that opioid agonist therapy reduces the morbidity and mortality associated with opioid addiction by a factor of 4. So massively effective for the treatment of all opioids, but in particular, buprenorphine is very effective for the treatment of codeine.
One thing that pricked my ears there as you were speaking, Bernard, was this idea that you mentioned and specified that relapse is an aspect of addiction. And that brings me back, I guess, to the program that you've developed with the Irish College around the topic of addiction more generally. And I like that stance that you outlined in terms of maybe taking the heat out of somebody's issue if they do relapse, that it is part of the modern way of thinking about addiction.
Absolutely, John. I think that was a big part of when we overhauled the program. It's really important we take a compassionate, understanding view of addiction. A lot of people who have addiction issues have also deep psychological trauma, huge underlying issues, and have difficulty coping with things that life throws their way. So I think it's really, really important that we have a compassionate, pragmatic approach. So there's no point sticking our head in the sand and saying, "Look, we've prescribed this for you. That's your problem's fixed." But we understand that relapse, people will go through bad patches, and like any of us, when we go through bad patches, we often revert to similar patterns of behaviour that we've exhibited in the past, and that's the nature of it. But the nice thing about this type of opioid agonist therapy is that there is a protective effect, as I've outlined before. So it's taking a pragmatic and compassionate approach. It's important we're safe when we prescribe these medications. That's why the training is important too. But it's important that we're compassionate and non-punitive at the same time.
And on that same note, when I would have thought about the opioid agonist therapy program, I would have thought of methadone and not much else. And you've already mentioned the idea of the green liquid and some of the stigma that can be attached to that. And if somebody would present to my practice with a codeine issue, I wouldn't necessarily have thought, okay, methadone. But from what you're saying today, this buprenorphine and buprenorphine naloxone combination medications, they're, I guess, a really useful, valid alternative, even just the simple fact that they're a tablet.
Yes, yeah, absolutely. And, if you think of the practicalities, John, a tablet is very portable. So it's discreet, it's subtle. Now, with the opioid agonist therapy programs, people still have to attend a pharmacy, and supervision is a component of that. And depending on how stable they are or where they are in their journey to recovery, then the amounts of times they'll have to attend a pharmacy will be varied. But for people who are very stable and doing well, many people will be attending the pharmacy once a week, and then they can get the other tablets as a discrete takeaway to bring home with them. So it allows you to continue, allows you to, for example, get on a plane easily, get a flight somewhere if you want to go on holidays, or if you want to travel for a hotel weekend break, you can do that discreetly without carrying bottles of green liquid around you with you. So it's a nice option. Now, I should say, John, that methadone is also a very effective treatment. So I wouldn't rubbish that. And lots of people have done very well on methadone, even for other, I suppose, non-illicit opioids, so things like morphine addiction or oxycodone addiction. But certainly for the weaker, milder opioids, buprenorphine would be a first-line option and a preferable treatment option. And like you mentioned, many of the most common buprenorphine preparations, things like Suboxone or Subsolv, which we see more and more often, would have a buprenorphine/naloxone combination. So they have a naloxone included in the formulation. Now that naloxone, I should say, isn't bioavailable unless people use the tablet inappropriately. So if you get prescribed Suboxone or Subsolv and you get the tablet and you crush it and try to snort it or inject it, the naloxone suddenly kicks into action and causes immediate opioid reversal. So it has complete opposite effect to what you're trying to obtain. So naloxone is just put in there to prevent diversion, reduce the street value and improve compliance with the medication. And that a lot of the beneficial effects of the medication come from the buprenorphine and the way buprenorphine partially agonizes and partially antagonizes the opioid receptor.
So buprenorphine naloxone sounds like a really wonderful product in the right setting. Surely there are some drawbacks to it. It sounds like all upside so far.
Yeah, and I don't want to paint it as too good to be true. And I should say that not everybody with codeine use disorder will require opioid agonist therapy, but I think what a lot of people get caught into, a lot of GPs get caught with, is people attending, and people are prescribing, GPs are prescribing codeine to people to sort of get their way out of a codeine addiction or codeine use disorder, which is very difficult, really, particularly when you think of the availability of codeine over the counter in Ireland at the moment. So I think it's very difficult to prescribe your way out of a codeine use disorder with codeine, particularly for people who have long-standing entrenched addiction issues with codeine. So in that cohort of people, absolutely, buprenorphine / naloxone in the form of Subsolve or Suboxone, they'd be the two main brands, is a great option. So there's a big part, like you alluded to there, John, the initiating buprenorphine is not straightforward. So you need a period of time without codeine to initiate that mechanism of action I mentioned, the way it tightly binds receptors. It bounces all other opioids off the receptors when you administer the buprenorphine. So it's important that people have a period of abstinence before initiating it. So for something like codeine, often, less than 24 hours is more than adequate. So you can start someone the next day if they've had their last dose of codeine the previous day. And even you can sometimes get away with less. But taking an opioid withdrawal score is a part of that to ensure safety. So it's the relative difference you see between the full activation from the codeine and the partial activation from the buprenorphine that accounts for this potential risk of precipitated withdrawal. It's very rare in practice, and if people are careful and have done the appropriate training, it's not an issue. But there are a cohort of people who just won't be willing to have a period of abstinence from their codeine, and in those people, methadone may be your most appropriate option. But I should say that initiation of opioid agonist therapy isn't a straightforward thing. And, that's something that we have would require additional training. So you mentioned the Foundation Addiction Medicine Program. For people who are interested, we have a certificate addiction medicine program, which is also known as the Level 2 program. So that would be the next step. And that certificate program is a prerequisite for commencing opioid agonist therapy in the form of either buprenorphine or methadone.
And I might ask you just to give a little bit of an overview on the Level 2 program in a moment. But before I do, getting back to, let's say, day-to-day practice and this patient in front of me who I now realise has an opioid issue, whether it's misuse or dependence, I guess from this conversation, if I'm not a Level 1 prescriber and I haven't yet done the training, let's say, thinking about your local addiction services through the HSE would be a useful thought to have for this patient, and maybe to get an assessment done by that service in the first instance before going further with something like a prescription of codeine, as you've said.
Yes, yeah. Look, I think, as GPs, sometimes we're reluctant to call out what we see as potential, misuse behaviour with medication. And sometimes we're afraid that it's going to create an awkwardness or discomfort by addressing it. But I think often people, when they attend their GP, they expect their GP nearly to call out some of these issues. So particularly, think of those people who are often requesting early prescriptions who shouldn't have run out, but who are seeking emergency supplies from their pharmacy. And call them in for a consult and say, look, do you think you have a problem with this medication? And you'd be amazed the amount of people who will say, yeah, look, I do have a problem with this medication, and listen, the pain that I had is no longer the issue, but I now have an issue with codeine. But I think directing people towards that opioid agonist therapy treatment path requires buy-in from the person in front of you as well. But as I said, there's such a huge cohort of people who are really distressed and have found sourcing codeine or another opioid to have such a debilitating impact on their life, and it's affecting all aspects of their life, that many people are just relieved when they do get directed towards the appropriate services. And as I said, they can commence an opioid agonist therapy, and that might be with a view to maintenance or with a view to tapering off the opioid agonist therapy, but it just means people can get back to living their life and no longer have this huge, overwhelming, burdensome issue of trying to source adequate codeine each and every day to provide them with, to cover their cravings and allow them to live a normal life.
And you mentioned at the outset, Bernard, how we all can bring to mind certain patients of ours where we may be aware of our codeine prescribing patterns, but your comments there also bring to mind the idea of a potential useful audit for a practice looking at codeine and how it's prescribed.
I think it's really useful, John. And there's a great medicines management program document safe prescribing of opioids in non-cancer pain. And you can use lots of components of that to provide your standard of care. But even just reviewing your chronic prescriptions for codeine within the practice and seeing is there an indication documented for that, and has there been a discussion with the person regarding the risks associated with that prescription. Even just something quick and simple like that can be a really useful audit for both you and your whole practice, and most importantly for the people you're looking after in your community.
And of course, getting back to the level 1 program, Bernard, it's not simply focused on opioids and OAT prescribing, but also around addictions more broadly. And from a prescription perspective, that also brings to mind things like benzodiazepines, pregabalin, and Z drugs. I guess that's also something to bear in mind in terms of co-prescribing with codeine and also prescribing in their own right.
Really important, John. I'm really glad you've brought that up because, it's something that, particularly those of us who are dealing with a lot of addiction medicine, we're really, really aware of. And I talked about being diligent with prescribing opioids before, but I think there's an extra layer of diligence needed when people are being co-prescribed. So there's a few classes of medications. So any opioids combined with benzodiazepines, Z drugs, or gabapentinoids, particularly pregabalin, people need to be really, really careful. So before you initiate a new prescription for something like codeine, check to see is the person already on diazepam or pregabalin, because that's a cohort it's really, really clinically risky. The problem really is, John, not only are all of those medications potentially addictive, but they also synergistically, so they all work together to impact the respiratory system. So they cause central nervous system respiratory suppression, which is really, really clinically risky. So I'd encourage you all to be really careful. And that's a good reason really to think about other options. If you are looking at a person and you're already prescribed, diazepam 5 milligrams 3 times a day and zopiclone 7.5 milligrams at night, and now they're looking for a prescription for regular codeine, really have a strong think about that, and outline your concerns to the person in front of you as well.
This has been really helpful, Bernard. So now I'm not just thinking about my opioids, I'm thinking about Z drugs, I'm thinking about benzodiazepines, I'm thinking about pregabalin, and on the basis that I'm listening to this conversation and I'm interested, I go ahead and I do my level 1 program. You already mentioned that to initiate OAT, the level 1 program wouldn't be sufficient. You need to go on and do the level 2 program. Could you briefly give me an overview of what would be entailed in that?
Absolutely, John. So the level 2 program it's a more detailed, nuanced approach to safe prescribing for primarily opioid agonist therapy, but we also look at things like alcohol, benzodiazepines, Z drugs, and pregabalin. I suppose really we focused the level 2 on addictions where there's an intervention for the prescriber, and maybe less of a focus on some of the more some of the addictions that are more psychological preponderance, like things like cocaine and cannabis, where the GP might assess but refer on. So it really empowers the prescriber to deal safely and appropriately with some of these other addictions. So there's a big focus on that, on opioid use disorder, all forms of opioid, be it heroin, morphine, OxyContin, codeine, and the medications we prescribe have particular rules and regulations regarding them, and particular precautions that are necessary for safe initiation. So anyone who's done level 1 and enjoys it and has a real interest, I'd really encourage people to consider the certificate level 2 program. And that, as I said, it attracts a slightly better contract with the HSE, but also it empowers you to really deal fully with patients with opioid use disorder, people with opioid use disorder, and prescribe safely and effectively for that. So it's sort of a blended learning course, John. I suppose the level 2 certificate course runs once a year, typically from November through to February, or that can change each year. And it consists of online presentations It also has 2 live webinar components associated with that, so 2 half-day webinars, and there's also project work associated with that. So people can complete either a clinical case workbook, which looks at real-life examples and practice prescriptions for these potentially tricky issues, or they complete a practice improvement project. Which is sort of like a quality improvement practice or audit-based project. So there's two different options regarding case submission, and then there's MCQs associated with each presentation. But it's a more comprehensive, detailed review, and really we have that credentialing and qualification there to make sure people who are prescribing opioid agonist therapy are safe in doing so.
Okay, I found this conversation really useful, Bernard, in terms not only of signposting towards easy to access courses provided by the college for anybody interested, and I'll include a link to those courses in the show notes as usual, but also in terms of turning my head towards the idea of referring to addiction services if needs be for those patients of mine who may have a codeine use disorder, that it's not just for things like heroin and the stronger opiates, as you said. In terms of wrapping things up today, are there any take-home messages that you'd like to share with listeners?
Thanks, John. Yeah, I think I maybe going back to the codeine issue, I'd love people to be more aware of the issue out there. And the vast majority of that codeine use disorder is actually related to over-the-counter codeine use disorder. So, first and foremost, it's great that I have this opportunity today, and just to encourage GPs to be aware. If people are approaching you for a new prescription for codeine, ask them, do they already have a supply of codeine? Are they getting it from someone else? Are they buying opioids online? Or, which is very common, are they going to the community pharmacy? And we know that Irish people buy huge amounts of this every year. We're one of the highest purchasers of over-the-counter codeine. So, it's a big issue, and it's very problematic, and we need to be aware of it. As GPs, we need to be aware of it. I'd like to encourage people who do want more training in the area, look at the ICGP education curriculum. We've updated both courses, both the Foundation Addiction Management course, Level 1, and the Certificate Addiction Management course, the Level 2, over the last 18 months. So, it's modern, up-to-date, best practice approach. So if anybody is interested in learning more, I'd encourage you to look at the courses available. And, I'd love people to be more aware when they think of opioid agonist therapy. Remember buprenorphine as well as methadone. So, we still use a lot of methadone in Ireland. Probably only about 10 to 15% of all prescriptions for opioid agonist therapy are buprenorphine. So, we think that's low as a percentage of best practice percentage internationally. And we think more and more people should be considering buprenorphine first line, particularly for people who are presenting new to treatment and people who have addictions associated with, mild to moderate strength opioids. They're ideal candidates to consider buprenorphine as an option for opioid agonist therapy. And maybe finally, John, I'd just like to say that as general practitioners, we're the best place specialty to deal with addiction issues. We understand better than anyone the overlay of, social context, physical issues and comorbidities. We know people and we know their families and we know their backgrounds. We know their history in depth, but also we can deal with the physical sequelae of addictions as well, really well. So, I think as GPs, it's a really, really rewarding aspect of general practice. And when you do it well, it can really make your practice very efficient. And people, I suppose, worry about getting bogged down. Prescribers worry about getting bogged down in these tricky cases. But if we do it well and we know the background and know an approach and a safe approach, it can actually make your practice very efficient. And you can be much, take a pragmatic, practical, quick approach to dealing with these issues. And knowing when to refer on when appropriate as well is really important.
Thanks again to Dr. Bernard Kenny for taking the time to speak to me today. Further reading can be found via the Irish College of GPs website, including an addiction management section with links to courses, including the newly revised Foundation course in addiction management. And as a reminder, relevant links to websites and resources mentioned in today's episode can be found in the show notes, where you'll also find chapter markers to aid navigation to areas of interest. As always, if you have any comments or feedback on today's show, or indeed any suggestions for future topics, please drop us a line at podcast@icgp.ie. That's it for today's show. Thanks again for listening, and until next time, take care.